everyone. Thank you so much for welcoming me, especially on this topic, which has, for the last 20 years, been really a flashpoint amongst my eating disorder colleagues. So one of the things we're gonna go over today is exactly what all of us. Is that yellow? So disclosures, I'm a board member for CEO of Mental Health. I'm on the NEDA and ANAD scientific advisory committees, clinical advisory committee for NEDA. I think it's always important to disclose bias, or to just acknowledge that we all have our own perspectives. We've all had our own trainings. I'm a thin-bodied person, right? I'm a white-bodied person. I'm a person with recovery experience, and not only in the eating disorder space, but in the addiction space and trauma spaces. All of that has influenced not only my medical training and psychiatric training, the research that I pay attention to or not, but also my practice and the patients that I treat. You know, most of the patients that we see at SunCloud have 3 or 4 active diagnoses at the same time. And a good portion of them have co-occurring addiction and eating disorders, which we have a specialty unit for. So we're going to review sort of a background of what the controversy is and the historical context. And then I'm going to go into the bulk of my presentation, where we'll talk about biology. Feel like the bio part of biopsychosocial, spiritual often gets left out of eating disorder discussions. And I think that's a key reason why over the last 20 years, we've had very little in the way of new and innovative treatments to push treatment outcomes. You know, and I'm here because my passion is really working for and working with that 30 to 40% who do not get better with our best treatments, you know, and that's not on them. That's on us, right? It's not because they didn't try hard enough, or they're too resistant, or they don't want it enough. It's because we have a lot more to learn. And, you know, I think all of us working together, I very much appreciate the acknowledgement of the divisiveness and how deeply people are being impacted with what's going on in the world today. I think in this, you know, for this hour in this space, like, can we do something different and actually engage in meaningful dialogue with people who maybe have different perspectives or different experiences? So I'll talk about neurobiology, assessment, some research on comorbidity and treatment, and then a trauma-informed and flexible treatment model. A lot of times people think, well, okay, Dr. Kim is talking about food addiction, so therefore at her treatment center, they probably don't even serve ultra-processed foods, or maybe everybody eats minimally processed foods at their meal support table. We have plenty of Cheetos and Doritos, and we have the whole point is we try to tailor treatments, including nutritional plans and meal plans, to the individual we are serving. You know, so if we were doing one philosophy for everybody, we'd capture a lot of people, but there would be people on the margins that we missed, right? And that's the whole point. You know, can we, as a field, can we at higher levels of care actually give people individualized care, even for their eating disorder, even with their meal plans? So this is me talking about food addiction at eating disorder conferences over the years. This is me getting on the bus, and here's how it feels when I get on the bus. I'm happy to report that, like, these spaces are no longer, like, so angry. I remember the first time I ever talked about food addiction, which is now called ultra-processed food use disorder. Brand new into my career, had that it was controversial at all. This was at what used to be called MEDA out in Boston, and it was a
real baptism by fire for me. That was definitely this. I don't see that so much anymore, certainly in the last 5 years. So I think I'm delighted about that, because I'm a person that, like our patients, that get caught in between two very different treatment recommendations, two very different ways of talking about what's going on. As a clinician who's in both camps, the space is artificial. The DSM is artificial, really. Like, we'd like things to be in neat little boxes, and they just aren't. Human beings don't come in that way. So the tension when we talk about ultra-processed foods or food addiction or ultra-processed food use disorder tends to come from us as eating disorder clinicians are very aware of the harms that restriction, rigidity, food rules, nutritional guidelines. Nobody in the country follows nutritional guidelines or even tries, except for our patients, right? Like, our patients with anorexia and atypical anorexia are like, I can't eat anything that's ultra processed ever again. And the vast majority of Americans don't pay attention to it whatsoever, right? So we're well aware of the obsessive, rigid, perfectionistic aspects that come along with people who have eating disorders. Addiction professionals, on the other hand, are very well aware of the problems that come with repeated exposure to triggering substances. And there's a biology behind that that's well evidenced in human studies and in animal studies. And the patients really get caught in the middle. And I see this a lot because I work with a lot of people who have a substance use disorder and an eating disorder. So the controversy really with this term ultra-processed food use disorder or food addiction historically had been the lack of a uniform definition. That's actually now changed. There's an international consensus definition on what this is and how we might define it and diagnose it. It has not yet formally been added to DSM or ICD, but it is, there are international groups working to get it into DSM-5 and the ICD. It's been submitted recently for ICD and in the process of being submitted for DSM. And not under, let me ask you guys, who, if let's say this is a thing, okay, and there's lots of evidence to say that it is, where would you think you would put it in the DSM? Which chapter? Eating disorders, substance use disorders, some other chapter? Anyone? Eating disorders? Yeah. Yeah. So, I mean, so in the substance world, there are substance addictions and process addictions like gambling, where you don't ingest a substance, but we know from the neurobiology that happens when a person with gambling addiction engages with gambling, that they have it. And we can tell by their behaviors and the criteria that they meet. So when I talk about ultra-processed food use disorder, and the international groups that I've been part of that are trying to get this into the diagnostic manuals, we're talking about a substance use disorder. We're not talking about an eating disorder, which is surprising, I think, to a lot of eating disorder professionals, right? And we'll talk a little bit more about the clinical distinctions, the theoretical distinctions, and why that is. There's a lack of evidence-based treatments, because if it's not a thing, how are you going to get NIH money or grant money to study it, right? There's a risk for harm with people who have eating disorders if there's misdiagnosis or inappropriate treatment approaches. In our field, when people hear food addiction, oftentimes they go straight to, well, if it's addiction, the only treatment is abstinence, right? And that's just not true. anymore in the addiction world. I mean, there are still plenty of people who say if you give somebody naltrexone, they're not really sober, but that's really archaic at this point. Or even, supervised injection sites, right? That is a form of treatment. There are many different forms of treatment for addiction. So I think we hear it as eating disorder professionals and we think, well, that means restriction. That means they don't serve ultra processed foods. That means diet culture, abstinence. That means weight loss. And it really doesn't mean any of those things. Finally, there's a lot of stigma still associated with addiction. And in the eating disorder world, tons of stigma associated with loss of control. I feel like in the substance world, there's like this hierarchy of like who's the sickest, and it's who's the sickest in the substance world. Anyone? I know some of you are from the substance field here. You have recovery experience, like I, who like in a substance use disorder treatment center, like who would be like which substance use disorder would be considered like the most dangerous and the sickest and yes. So, right? Like IV heroin, right? Like, oh, I'm just an alcoholic. I don't have like heroin addiction, right? Like that's like, ooh, everybody like a lot of focus on that, right? In the eating disorder world, what is that thing? What is an inordinate amount of our research and treatment focus on? Yes. What is the least common of the eating disorders? Yes. Right? And what happens to people with binge eating disorder when they go to higher levels of care? That most higher levels of care for eating disorder places have high amounts of people with anorexia and bulimia. We're like the odd person out in the eating disorder field because most of our patients, the average, if we look at BMI, if we care about BMI, the average BMI of most of our patients with eating disorders is higher, right? That's the inverse of what it's like at most treatment settings, right? So I think we've done a disservice inadvertently to people with binge eating disorder, people with out of control, loss of control eating phenotypes, because of a lot of different reasons, some of that we're going to cover here. And I really wish we had like 3 hours for this talk, but we only have an hour, so I'm going to try to go fast. Okay. Historical context, food addiction, this slide really just says food addiction is something that was first coined back in the 1950s. It's gotten a really bad rap. Overeaters Anonymous, any fans of Overeaters Anonymous in the room? Any like strong like dislikers of Overeaters Anonymous in the room? Okay. And then in the 80s and 90s, talk of anorexia as a starvation dependence. But back in the 90s, many eating disorder, when people went for eating disorder treatment, it was all addiction models. And then in 2000, that sort of went away and was sort of shunned and like, that's not really what this is. But also in the late 90s, early 2000s, research started coming out with Bart Hobel, Nicole Lavina on animal models showing, Mark Gold at University of Florida, showing the addictive properties of certain food substances. And that's a robust literature. And then, in the last 10 years, there have been more and more studies on human subjects, both treatment studies and diagnostic studies. And this is just a nice visual way to see the explosion of research literature. And this slide ends at 2014. It's continued to rise steeply. So this is something that is obviously talked about all across the country. It was all over the new nutritional guidelines, right? It's our patients are hearing about it. We have very intelligent, well-informed patients that I think we try our best to talk out of their intelligence a lot of the time. I'm not sure how well that works.
So I think there's more to the picture. So why is this relevant to us? Why should it be relevant to us as eating disorder clinicians? One of the gold standard treatments for binge eating disorder is CBTE, right? So everybody know, all the eating disorder people in the room know what that is, right? It's highly, highly evidence-based, gold standard, but it's only moderately effective. It only works for, 40 to 70%, depending on the study, of people with binge eating disorder. So what about that other 30 to 50% of people, right? Do we keep trying it over and over and over again? Like, well, you didn't try, mindful eating hard enough and you weren't ready. This is the message and the hopelessness that I think you beautifully described, right? Like, that ends up with people feeling like there's something wrong with me, I'm broken, there's no help for me, versus what if we as clinicians said, you know what, I'm going to recommend the gold standard treatment for binge eating disorder. It works for a lot of people, but not everybody, because we know only a little. Like, how often in our practice do we ever say that to a patient? Like, I'm limited in the tools that I have as a doctor, as a physician. We know only a little. And I think when we act like we know it all, we know it for sure, and for everybody, we are hurting people. And I know that, like, as a clinician, nobody in this room none of us came here today or chose this field because we want to hurt people. Yeah. So for those people, the ultra-processed food use disorder or addictive eating, or that brain circuitry and those genetics, which are oftentimes associated with other substance use disorders and trauma, may be actually a paradigm that shifts things for some people. So CBTE came from Chris Fairbairn's transdiagnostic theory. What does a theory mean? Right? A theory is something that somebody thinks. It's not based on evidence, right? There are a lot of research that has been done since the transdiagnostic theory to substantiate many parts of it, right? But this is pretty much what we've been using since 2000. And our outcomes have been improved since 2000. And this was made at a time when the only eating disorder diagnoses in the DSM were anorexia and bulimia, right? And then EDNOS, EDNOS, right, which is now OSFED. So the model forms the basis of most of the cognitive behavioral therapy that we use today, most of the nutritional philosophies that we use today, right? Eat at regular intervals, 6 times a day. Has anybody seen a study that looked at, eating 6 times a day, 3 meals and 3 snacks versus eating 5 times a day, 3 meals and 2 snacks? No, because it's not out there. But we always say, we always start with 3 meals, 3 snacks. Do a lot of people start with that? I mean, it's pretty standard, right?
I start with are you even eating 3
meals
a day?
With many patients, it's can we have 3 eating time that you commit to eating at least 3 things? Yeah. But in controlled settings, right, in residential treatment centers or partial hospitals with partial programs, we're supporting patients in eating. And a lot of that comes from it's just what we do, right? It's just what we've always done. So one of the things I do with my dietitian team, my nutrition team at SunCloud, is I push them on that, especially when the patient has, not anorexia nervosa or atypical anorexia nervosa, but maybe has binge eating disorder, type 2 diabetes, hypertension, maybe is a person from a minoritized either gender group or racial group that isn't the person that the transdiagnostic theory and all of the subsequent research was centered on, right? So, and that person saying, I think I don't want to eat 6 times a day. Like, who does that? Most people out in the world aren't eating 6 times a day. In our field, we're like, yeah, everybody eats. Like, it's easy. Spending 20 years in the eating disorder field, I sometimes forget that many people aren't eating 6 times a day. So I think it's important to recognize where this all comes from, and also dietary restraint. So the whole basis of the transdiagnostic theory is, regardless of eating disorder diagnosis, dietary restraint is the thing that is key to target. And when you think about all of our treatments and all that we work on, it's really like, do you ever do challenge foods with your patients, or like challenge meals? Like, what would a challenge be for a patient with an eating disorder? What kind of challenges? Who's done a challenge with a patient recently? Okay, right? Dessert, right? Like, we're gonna have a challenge. We're gonna eat dessert together in the session. Have any of you done a challenge of like not eating the whole cake? Have any of you done a challenge of not eating the cake? I'm getting, for people on Zoom, I'm getting strong no's on that, right? So part of that is because we're very, very focused on combating dietary restraint, and for good reason, right? We know that undernourishment increases the risk of subsequent binge eating and can worsen a binge restrict cycle. I would say that not all binge eating disorder is binge restrict cycle, but I think most of us start with that as what we're looking for, right? This is a study done, I think just last year, looking at the role of dietary restraint in binge eating disorder. And it was really a study looking at using a partial correlation networks to identify what goes with what's associated with what. And it wanted to look at the pieces of the transdiagnostic theory. So they had 400 patients with anorexia, about the same with bulimia, and 250 with binge eating disorder. And the results were consistent with the theory. The networks are very similar in the 3 diagnoses. Core low self-esteem and overvaluation of shape and weight and dietary restraint are connected to each other in both anorexia and bulimia. Binge eating and self-induced vomiting closely linked. But what was in contrast to the transdiagnostic theory is that dietary restraint was not linked with binge eating, and mood intolerance didn't show strong associations with eating disorder behavior. So this idea that all binge eating is caused by dietary restraint is certainly not consistent with every patient that I've ever treated. Isn't consistent with what you shared today. I've treated plenty of patients with binge eating disorders, with what I would call ultra-processed food use disorder, or ultra-processed food use disorder actually is also not a good name, because there are plenty of ultra-processed foods that don't have addiction potential. And there are plenty of ultra-processed foods that actually benefit health. It's a huge category of foods, but it's the best we got right now, but it's not great. But I think this is a really important study because it actually, sheds some light on the fact that there's something we're missing, particularly when we're thinking conceptually about binge eating disorder. So there's got to be more to the story, than just the trunk of the elephant. And part of that, I think, is addiction. So when we talk about addiction, it's a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's biological. It's a brain disease. This brain disease has characteristic biological, psychological, social, and spiritual manifestations. And it's reflected in an individual pathologically pursuing reward and or relief. Many people use substances, including food, to relieve negative affective states. That's part of what connects addiction and trauma so closely. And this is just a very general schematic of what that circuitry is. Am I really at 0 minutes?
No.
Oh. We have a lot more slides now. Oh.
Countdown.
It's 12:20.
Oh, okay. Good. So this reward circuitry starts in the brainstem, the ventral tegmental area that sends dopamine-rich neurons to the nucleus accumbens, which is the reward center, but also sends projections to the orbital frontal cortex, part of which helps us inhibit behaviors when we don't want to do it anymore, like stop eating when I'm full. Part of which also helps us decide what to attend to in our environment. There are so many different sources of input, neural inputs. This part of the brain for people with addiction gets focused on whatever the substance or the behavior is. There are studies looking at this in anorexia that show the focus is on thinness and on there are neurobiological studies showing that actually it's more about the thinness and not about the food or food aversion. So it's even when people don't have addiction and don't have a food addiction, there are studies that have looked at the reward circuitry in eating disorders. So it's relevant even to people with eating disorders, as much as we don't like to. There's something that feels dangerous about sharing it in eating disorder circles, right? Like, we don't want our patients to avoid pleasure. Like, we can't talk about the reward circuitry as possibly being hijacked in some way or aberrant in some way. When we talk about eating, it's a lot more complicated because there are all of these other parts of the brain that go into how a food's texture is responded to. The somatosensory lobe, the amygdala and the temporal lobe. When you guys think about, so much in our culture, we associate food and eating together with fond memories, for some people, traumatic memories. So it's much more complex with food. How many of you think all foods are created equally? Mm-hmm. How many of you tell your patients that? Okay.
I say food is not like morally one way or another. That's how I talk to people about
Right.
It. Like there's a good or bad, but
Yeah.
I don't say they're created bad.
Okay. Because what patients, yeah.
It's also about how food is grown and then how food is biochemically made in our society too.
Correct.
That's not equal.
Correct. Correct. So all foods fit, but they are certainly not equal, and oftentimes, particularly with patients with anorexia, who are highly intelligent, I think we try to give them the message that, like, a carb is a carb, or, it's just a macro exchange. Come on, believe it, But we know from massive studies on like 10 million patients that ultra-processed foods are linked to certain health conditions, type 2 diabetes, cardiovascular risk, and mental health conditions like depression and anxiety. These are amoral conditions. There's no morality about heroin is an amoral substance, right? Cocaine is an amoral substance. In the midst of a surgery, if you use cocaine, you can control bleeding. If you have cocaine addiction and you use cocaine, it's going to give you a much different outcome, right? So we take things out of the moral plane and put them into very practical terms for our patients. Is food a psychoactive substance?
Yes.
Who said yes? Yes. Awesome. How do you know?
We feel differently depending on what we had or interacts with our own biology.
Yep. So think about the best broccoli you ever had. Is anything coming to mind? Think about the best dessert you had over the holidays. Right? Is something coming to mind? Who wants to share their best dessert over the holidays? Best broccoli dish or best dessert? Does anybody have a, right?
It's broccoli parmesan in a nice restaurant.
Yeah.
Dessert, apple pie made beautifully, because every other year it's ugly.
Amazing. And when you think of that apple pie and like having it with family or having it at an event, it brings a whole nother, yeah. So that's psychoactive. You know, that's in your brain and your gut. And we don't spend a lot of time with our patients with eating disorders talking about what's going on in their brain. And when we don't, people feel like they're crazy. They just can't stop because they're not trying hard enough. Or they feel like so isolated from the person that's trying to help them because they're experiencing something and we're not seeing it. We're not at least saying that we see it, right? Because we don't know a whole lot about it.
I think there's something wrong with that.
Yeah.
When they really, the brain chemistry is different.
Yeah.
It's reactive.
Yeah.
So
it's exactly right.
they feel like they're broken.
Yes. Especially if they're in settings where they're being told, like, okay, the challenge food for the meal support table today is cupcakes, and we're all going to eat them mindfully, and then we're going to use our skills afterwards. And then if that person goes home from day treatment or the meal support group and has 12 more, 24 more, what do they feel like? I'm a big failure, right?
We're having some questions on the Zoom about could you define what ultra processed food is for us?
Yeah. I have a slide in another presentation. If I had an hour and a half, I could do that. I'm just kidding. So, are you familiar with the NOVA food classification system? Okay, it's a classification system that's been around for years that came out of a university in Brazil. And group 1 foods are naturally occurring foods. So an apple off of a tree or corn that you grew in your garden. Group 2 foods are things that we would use in like common culinary processes. So like salt, things that you can't find like outside, but you get from the store and typically use when you eat. Group 3 foods are combinations of group 1 and group 2. So technically, a group 3 food would be considered a processed food, but it would be things like homemade, made from scratch. Like desserts would be included in that if they're made from scratch. Group 4 foods are foods that have very little in the way of whole foods in them and have all like the ingredient list that's 25 ingredients long, many of which you've never seen before, things that aren't naturally occurring, things that are chemicals that are designed by food scientists paid by Nestle to increase their profits, to get you to eat more. They're designed to kind of hijack this system and shut off your brakes and turn on your gas. That's what ultra processed foods are. But this would be like things that are included in this group are like Dolly Madison ho-hos, right? But also included in this, which is why it's a problematic category, would be yogurt that you buy from the store, right? That has, strawberries and added sugar. That would be considered an ultra processed food. So some of these foods, like whole grain breads, would be considered this. So some of these foods have not been linked to health issues. And particularly for our patients, if you say ultra processed food use disorder, they hear like, oh God, I can't eat any of them ever, 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 right? Or they read the nutritional guidelines and say, I can't have added sugar ever, ever, ever. There are some people with food addiction who can't have added sugar and do that in a safe way. And that's not because they secretly have eating disorders. It's not because, they're orthorexic. It's because they have a very sensitive reward pathway that gets triggered and revved up with these substances. The good news is we all have to eat, and we can all eat in ways that honor our bodies, right? And that's not going to be the same for person X and person Y. So person X, doesn't want to like cut out like sugar, right? Or flour, right? And doesn't want to like limit their foods. Great, you know, and if person Y does, and they don't have anorexia or atypical anorexia, why not honor that, even if it's just a patient preference, right? Because we have a lot of fear about restriction, right? Like, oh, that would be rigid, right? Rigidity gets a really bad rap in our field, but we all do rigid things every day, right? How many of you brushed your teeth this morning? Do you do that every morning? I would like to challenge you to not do that for the next 3 days. You know, so there, you know, it's context is so important. Biology is so important, and lived experience, I think, is, you know, another important part of this. And if we're doing the same thing, like I see people at my treatment center who've been to really good treatment centers, and I'm not going to do the same thing. You know, I'm just not going to waste their time, their energy, their insurance dollars to do the same thing, because when I do the same thing, the implicit message is you just weren't ready, or they didn't do it right. And like, I have a lot of colleagues in this field, and we all know how to do CBTE, you know. No question.
I was gonna say, I feel like there's also so much unresearched stuff in regards of like chronic illness. You know, like the interaction between hormones, especially for women. You know,
Yes.
conditions like PCOS or endometriosis, or even like certain forms of cancer.
Yeah.
And like then I think that throws us into a different topic. But then the interaction with certain foods, or you know, the like why some people may be rigid
Yeah.
about certain things like that.
Yeah.
Or not eating certain things.
Yep. Yeah. So all foods fit. They don't for everybody.
Yeah.
Does anybody have celiac disease? Yeah. So I wouldn't give you like back 10 years ago, right? 15 years ago in treatment centers, you know, that's just your eating disorder. You have to eat all food, right? Like we actually did that as a field. None of us would do it today. We actually honor vegetarianism. You know, we didn't used to. Veganism, we didn't used to. There are many ways to nourish people. It can't just be one way or the highway, because then we're alienating a lot of people. And I'm here to tell you that most of those people are people with living in larger bodies, Black and brown people, and people that all of our research, you know, wasn't really built on. Okay, so do you want to learn a little bit more about addiction and like potency and like what makes certain things have greater addiction? So first of all, I want to start with who thinks substances cause addiction? Nobody?
I think some substances can be powerful enough that the brain will, you know, the dopamine that will be like, wow,
Yeah.
this is pretty amazing.
Right.
And
does everybody that uses an addictive substance develop?
no.
No. Right. Does everybody that uses, that eats, we're all, I think like almost 70% of our food supply chain is ultra processed foods, which is different than some other countries that are faring better than us. But all of us are exposed from very young ages to ultra processed foods. The prevalence of ultra processed food use disorder is around like 12%, 12 to 14%. So for sure, not everybody develops addiction. Not everybody that uses cocaine develops addiction, or heroin even. But we know that addiction potential increases with the potency of the agent, like you said, and then also pharmacokinetics. So how quickly it passes over the blood-brain barrier, right? If something, let's use benzodiazepines as an example. Klonopin or clonazepam is a longer-acting benzodiazepine, right? It has addiction potential, but it's a slow onset, kind of peaks off slowly, and then slowly falls off. Xanax, on the other hand, alprazolam, is you feel it right away. Addiction is so much about like urgency. I have to have it right now and I can't not have it. I actually needed it yesterday, and Xanax does that very well. So glucose does that very well. So when we think about glycemic index of food, high glycemic index foods have a much more pronounced brain effect than low glycemic index foods. It's similar to that slow and foods, meals that have, like all of the like protein and fat and carb tend to do a lot better for people in the way of glucose spikes than meals that are all carbs, right? So part of what makes things addictive is the potency of the medication or the substance, and the other part is how quickly it goes over the blood-brain barrier. And high potency, quicker acting has higher addiction potential. These are the DSM criteria for substance use disorder. So the group that's working to get ultra-processed food use disorder into the DSM is basing the criteria directly on this. So substance use disorder criteria in DSM-5, it's all the same criteria for each of the different agents. Because addiction is a primary brain disease. It plays out with different substances, sometimes over the course of a person's life. Alcohol, then nicotine, then food, or many people have multiple types of addiction at the same time. We see a lot of that. But these are the criteria. If you have 0 to 1 of these criteria, no diagnosis. 2 to 3, you have a mild substance use disorder. 4 to 5, moderate. 6 or more, severe. And it centers around compulsive use, continued use despite consequences, loss of control, and tolerance and withdrawal. There are groups that have developed a food withdrawal scale. Erica Lafata at Drexel, Ashley Gerhardt has done some of this work as well in developing a processed food withdrawal scale. And somebody asked me, well, what are the symptoms? And did you ever experience any withdrawal?
A little bit, yeah. So headache.
Yeah.
Headache big time.
Headache, irritability,
Fatigue.
Insomnia, like sleep disturbance. There's another one, fatigue. So eating disorders and ultra-processed food use disorder are overlapping. It's kind of like diabetes and hypertension. They're overlapping. There's a lot of co-occurrence of those two, but they're distinct. We happen to know a whole lot more about diabetes and hypertension than we do about eating disorders or ultra-processed food use disorder. But this is a chart that shows. So if you see the double X, this criteria is required for diagnosis. So binge eating episodes required for a binge eating disorder, required for diagnosis of bulimia, not required for anorexia restricting, required for anorexia binge purge, not required for food addiction. Does that surprise anyone? Yeah. So there are different phenotypes of addiction, and you can think of somebody who binge drinks versus somebody who smokes cigarettes or hits their vape all day, right? So there's a graze eating phenotype that has been described with food use disorder, where the person never consumes an objective binge, but they're consuming foods and feel like they're obsessed with the foods and can't stop eating the foods at a sort of like slow drip all throughout the day. The other thing that's absent for food addiction is all of the things that our lived experience speaker shared that she didn't have, like intense fear of gaining weight and self-evaluation unduly influenced by body size and shape, body image distortions, restrictive eating. When somebody doesn't have those, there's something more going on. And granted, sometimes our patients will say, like, people who are undernourished, severely undernourished with anorexia, many of those people don't have body image concerns. They like their body that way, right? In the disease state. But you see those emerge as they start renourishing, right? But when somebody is not in a malnourished state, they don't have body image issues, never have body image issues. There's something more going on than an eating disorder. Despite a high percentage of individuals with binge eating disorder meeting criteria for ultra-processed food addiction, about 50%, most people with ultra-processed food use disorder do not have an eating disorder. They do not have binge eating disorder. So the lifetime prevalence of binge eating disorder is around 3%. And the prevalence of ultra-processed food addiction is closer to 15%, which is similar to the prevalence of other addictive disorders, around, anywhere from like 10 to 15%. In studies that have looked at people with binge eating disorder and compared people who meet criteria for ultra-processed food use disorder to those who don't, they've shown that the people with BED plus ultra-processed food use disorder have more binge eating episodes, more intense food cravings and preoccupation, worse emotion regulation and self-esteem, worse negative affect, and higher incidence of comorbid mood disorders. I think we've covered a lot of this, and you guys will get the slides too. So if we go over this a little bit quickly, because I want to get to the treatment part of it, because that's always the question. Like, great, it's a thing, great, it's not an eating disorder, but what do you do about it, right? Lots of comorbidities with ultra-processed food use disorder, both medically and psychiatrically. And psychiatrically, eating disorders are highly comorbid. The most comorbid with bulimia, actually much higher than with binge eating disorder. We know that ultra-processed food use disorder mediates treatment outcomes for people with eating disorders. So in response to CBTE, for example, people who have comorbid ultra-processed food addiction have less treatment engagement and more dropout, less reduction in binge eating frequency after a course of CBT, and lower rates of full remission at the end of treatment. And multimorbidity is the rule, and I particularly want to stress the role of trauma. When we at our treatment center, we have a research team, and one of the things we look at is the rates of PTSD. Up to 70% of our patients meet full criteria for PTSD or dissociative subtype or complex PTSD. Most addiction treatment centers, that number is around 50%. And it's similar for eating disorder centers as well. And I think ours is so much higher because y'all won't send me simple patients. No, I think it's higher because we treat a lot of people with both. And whenever there's both, there's usually a higher trauma burden and earlier trauma. And that impacts the reward circuitry early on in life and sets people up to needing relief, right?
My last question was trauma right now, like treatment.
Yep.
So I have been working with complex trauma and also applying applied neuroscience, more specific and variability biofeedback. But then most recently I've been working in a hospital and eating disorders. And I was very surprised on how, the 6 meals for patients who have trauma or who complex trauma of some origin, that they're sitting down to eat, they are in a state of fear.
Yeah, complete dissociation.
They dissociate into fear.
Yeah.
And so we know, the justice system is not working, can't function properly or response.
Yep.
But the expectation is that you have to eat this 6 meals throughout the day, and the patient has trauma.
Yeah.
I just found it to be kind of very incongruent.
Yes.
With what we know, addiction, the neuroscience, how the brain and the body works together, and also treatment. That's
exactly right. There's been, I think this is still a shortcoming in our field. We're still operating on the mentality of, well, you have to be renourished first, and then we'll address your trauma. Studies show actually the opposite,
Yes.
you know? And many people aren't going to get renourished unless the trauma is addressed at the outset of treatment, even for people who need a lot of renourishment, regardless of their body size.
And I think what I perceive, it's almost a re-traumatization of
Yes.
patient, because what's happened is that, okay, I'm gonna make it,
Yep.
right? And I'm gonna, which is a pattern of trauma that they might have had for all their life,
Yeah.
childhood.
Yep.
So then they have to please the system
Yep.
in which they have been.
Yep. That's exactly right. And there's a slide at the end that talks about, you know, how sometimes I think we inadvertently re-traumatize people by trying to talk them out of their lived biologic experience, you know, and say like, that's just your eating disorder, or don't worry about your diabetes.
Yes.
You know, when they've had 5 family members needing limb amputations,
Yes.
you know, stop focusing on your diabetes. You know, like, don't listen to your endocrinologist. Sometimes we have to say that because the endocrinologist is saying like terrible things to a patient with an eating disorder. But always pick up the phone and talk to those providers, please. You know, but that's exactly right. You know, I think we, because it's like gaslighting a person to say, you know, that's not actually what's going on. You know. When actually it is. Even just saying to a patient sitting on meal support who looks completely dissociated, even just acknowledging, I can see the terror in your face and in your body, and I could see the dissociation all over you right now. Even just that is healing for people who've gone so long invisible. You know, thank you for bringing that up. So in the last few minutes here, treatment, and it's very relevant to trauma. Like any treatment that's not trauma informed and rooted in trauma practices is not really going to work. And so much of what we do is very paternalistic and prescribed. I'm going to prescribe your meal plan to you, and you have to eat this much and in this way. And if you don't, you won't get your privilege, or you'll be considered, you know, resistant to treatment, and you're not going to make it through till graduation. None of us say it in that way, right? But that's sort of like the implicit, you know, okay, here's what the game is. Here's what I have to do. If I can't do it, I'm bad. And it's something that involves my body, and many of our patients have had, you know, sexual abuse, physical abuse, that nobody's talking about. So screen for ultra-processed food use disorder. I have colleagues who call me reckless for giving people the MyFast. Like, you're going to harm them by even giving them the modified Yale food addiction scale. You're putting bad ideas into their head. So we studied it, actually. So does screening for ultra-processed food use disorders worsen dietary restraint in people with eating disorders? We have the luxury at our treatment center of having a lot of people with eating disorders and a lot of people without. You know, so we looked at, these are the non-eating disorder folks, and this is the EDQ restraint subscale at admission. Low, as you'd expect if you don't have an eating disorder, stayed low. And for people with eating disorders, high when they come in, and then it decreased. And all of these people got the MyFast at admission, at discharge. All of these people were in a milieu where some patients were getting treatment for comorbid food addiction, eating disorder and food addiction. And there's a lot of fear, and there's a lot of perceived fragility, I think, in our patients. Like, you can't say that word. You're going to derail them, you know, like they're not that fragile. Especially if a milieu is normalized to bodily autonomy, individual care, and what's working for me and what I'm focusing on might look different than for you. But what's similar is everybody's working on trauma, you know? So there's some data on treatments for ultra-processed food use disorder. Some of that is medication. So naltrexone, bupropion, Contrave, which I'm sure some of you have heard about, has been shown to have some efficacy. There are studies that look at bariatric surgery that are mixed, and then low efficacy, not a surprise, behavioral weight loss and lifestyle interventions. There are studies that look at lower carb meal plans and ketogenic meal plans. There are lots of studies going on right now. There's a study actually that Guido Frank is doing at UCSD, looking at ketogenic meal plans for people with anorexia. And I looked at some of his data, which was extremely promising, but it's really hard to do.
Yeah.
Really, really hard to do. Yeah.
Any data on stimulants?
Specifically for ultra-processed food use disorder, not that I'm aware of, but that's a great question. There's a study that looked at GLP meds that was promising, and that's consistent with the studies that are coming out for alcohol use disorder and GLP meds. But people oftentimes think about abstinence again as the only treatment, and harm reduction is what we use. I think all treatment is harm reduction. You know, even for people who come in with alcohol use disorder who say, I never want to drink again, it's a matter of harm reduction because they don't also stop, sexting the guy next door or, like vaping or all the other stuff the day that they stop drinking alcohol. So it's, we're gradually bringing people towards their, God-given fingerprint in recovery. And that's a lifelong, there's no ceiling on spiritual growth, none. So recovery, goes on forever. I think it's all harm reduction. Some people, there are studies in this ultra-processed food use disorder world that have looked at harm reduction and show that they're beneficial not only for using ultra-processed foods, but also eating disorder cognitions go down as well. So there's hope and there's promise for people who do have both, because there are people who do have both, that there are treatment approaches that aren't going to make one worse or only treat one and make the other one worse. Right. Yeah.
What's fun studies are so minimized in terms of this. We used to study thousands every day.
Yeah.
Now we take the gospel. That study just shows 107.
Yeah. Well, these are very, very it's very preliminary.
Because we start talking about it. Next you know, we gotta be adjustments.
That's yeah. The ketamine problem is like we talked about that at dinner last night.
Solve addiction problems.
Yeah.
We're 20 years away from knowing.
Very, very, very far away.
Problem is we have
lots, and we have people. We have like AI prescribing it essentially. Yeah. We have internet people who aren't, where the doctor never sees the person rendering treatments. So I think the thing to remember from this talk is it is a thing. It's relevant to some of our patients, and there are different ways to treat it. Treatment, standard eating disorder treatment as usual. All foods fit in moderation. Is good for many, many people, but not everybody. So harm reduction is another model, and that might look like limit, instead of eating 90% of your daily intake consisting of ultra-processed foods, adding in 30% of minimally processed foods and getting that number down to like 60% or 70%. For some people, it might look like having identified trigger foods, which is not the same as a fear food. Like a trigger food is think of it as like biological, biochemical. Having those with abundant support in social settings, but maybe not having them in your house. And this can change over time for people too. So I think flexibility is also a really important part of it. And doing the experiment with patients, really collaborating with patients and saying, I don't know, let's give it a try. Because we don't have the studies, But you have something going on. And then abstinence-based approaches, which some people use. It's been the minority of patients. We give patients at the treatment center who have food addiction the option of which of the approaches they want to try. The vast majority of people either say eating disorder treatment as usual or harm reduction, and very few are opting for abstinence-based approaches. Yeah.
Do you have a clinical recommendation as to how to like communicate to a client about this? Because if I sit down with somebody with anorexia and I say, this yogurt you can eat, this yogurt you can't eat, because one's ultra processed.
I would never say that to anyone.
So can you give me some guidelines on
Yeah.
how to communicate that?
Yeah. So it's very patient driven, right? And this is where experimenting with somebody comes in. The non, there's a data part of it where you can give somebody a MyFast or a FAST. The FAST is the food addiction symptom inventory, which is clinician administered, which is much, much better than the self-report.
What is it? Food addiction?
Food addiction symptom inventory, the FASI. And then if somebody has it, you can describe to them what it is. And the fact that we don't have much data at all on how to treat it, and when we don't have data on how to treat something, if I don't have data on how to treat something that a patient has, I rely on three things: patient preference, my own clinical experience, and similar things from the research literature. So the similar thing from the research literature is addiction, right? And abstinence works for only a small percentage of people. Harm reduction works for a lot of people. And there are different types of treatment, so starting with the humility and the reality of like, we don't know, but let's try to figure it out together. One is trauma informed. Two, it's just honest, and patients know when we're lying to them. They always do, because they've had trauma and they can read a room, So relying on those three pillars, we build treatment plans that sometimes change over time. Like, I don't know, what do you think about that yogurt? Is it something that, 90% of the time you can't stop eating? Or is it something that, let's pay attention to your physical reaction, your emotional reaction, and what happens the rest of the day for you when you eat it, right? And patients know that, like those little lemon cookies, like you knew what they did to you, right? So I would say, in this scenario, I would say, well, what do you think about those little lemon cookies from Trader Joe's? Do you want to try to have them only when you're like out with your, I don't know, at your, brother's house, right? Or do you want to try to have them on a daily basis? Like, where do you want to start? And then we'll start there and we'll monitor what happens. And we can pivot if it's not working. It's basic trauma informed. I'm not your God. I don't know your answers, but my job is to help you find your answers. And I've been trained to do that. And I'm here to do that. Yeah.
And adding to that, I think many people have been so detached from their bodies.
Yes.
This approach helps them to be curious. Let's be curious together.
Yes.
About when you're eating this food and what's happening in your body.
Yeah, I'm not another person that's going to show up and tell you what to do to your body. Yeah.
We have a question from online, and then we might have to.
See, we needed 90 minutes.
I know.
This has been great.
With foods, is it more about reward center pathways or expression of compulsive personality traits? I would love to see overlap with these proposed DSM food addiction behaviors to other compulsive behaviors in the same individuals.
What does compulsive personality traits mean? That sounds like addictive personality, which is a term that we use a lot, but it really just describes. But there's a lot of overlap between OCD and the reward pathway. The dorsal, the frontal tegmental area loop. It overlaps with OCD and addiction and eating disorders, anorexia particularly.
On that, that was one of the questions I had with OC and how it's showing up. Were you considering that underneath the anxiety, that prevalence of that slide earlier, or is OCD kind of being separated out and how that's showing up?
I don't even know if like people are even looking at that at this point, other than like we see it often clinically.
Because you're saying with the bulimia and kind of food addiction and whatnot, like that's showing that there's some roots of OCD that's popping up here. It doesn't show up the other ways, but
yeah. No, we know there's a lot of overlap between OCD and addiction as well.
And this is where I see clinically the link between the compulsive nature of an addictive food use and the impulsive nature of ADHD, and where we cross over with stimulants, and especially if you can get a stimulant that lasts all day long,
Right.
and not up and down in effect to taper, but you can get a 12 to 15 hours stimulant coverage and the compulsivity goes down. And that's where I would love to see some more data.
Yeah, I mean, there's
outside of binge eating in particular, but this
Yeah.
food compulsion, food searching, food seeking, the reward that comes in with that. So
Yeah, there's a lot of data on ADHD and treating ADHD to mitigate substance use risk
exactly.
for kids. You know, I think because of exactly what you're
And
talking
I think
about.
we're so frightened when we have somebody come in with an eating disorder to even consider the topic
Right.
of a stimulant, but sometimes it's exactly what they need.
Yeah.
Where we got to get them stabilized and safe before we can add that on.
Yeah.
But I frankly use it a lot.
Yeah. No, that's right. That's another like rule, you know, like all or nothing.
Right.
Yeah, nobody with an eating disorder can ever get their ADHD treated or their diabetes treated. Sorry. All right. Thank you all.